Okay. Right, Piyush. You've been, GP's referred you a 24-year-old gentleman for a vasectomy. What are the key points you want to elicit in his assessment?
So in this patient's assessment, I'll start by taking a focus history. I'll ascertain the reason he wants a vasectomy, whether he's completed his family, and I'll then ask him about his past medical history, significant points including any previous inguinal scrotal surgery, including inguinal hernia repair or awkward apexy. I'll ask him about any previous scrotal pathology. I'll assess his general fitness for surgery, and I'll then go on to perform a physical examination, offering a male chaperone. I'll note his body mass index. I will examine the abdomen and then the external genitalia. I'll examine the testes to ensure there's no obvious palpable abnormalities, and then I will palpate the vasa bilaterally to ensure that they are palpable and present. And depending on my clinical, after my clinical assessment, I'll then go on to counsel the patient about vasectomy.
Okay. You mentioned about his body habitus. Why is that important?
With regards to vasectomy, the importance of this will be helping to determine whether how easily the vasa are palpable, and whether whether the procedure will be more appropriately performed under local or general anaesthesia.
Okay, you also mentioned examining his abdomen. What's the significance?
This would be just to, I suppose in this scenario, there isn't any specific significance, just to ensure that seeing if there's any previous surgical scars, for example, in the inguinal region, suggestive of previous surgery, and therefore potential difficulties with the surgery.
Okay, the patient's heard a lot about testes or epididymal pain post-procedure. What would be your advice to him about this?
So I'll explain to him that there is a chance of kind of chronic scrotal or inguinal pain occurring after the procedure, and that the risk of this is in between or less than 2%. I'll explain that there are no known risk factors which can predict whether or not this will happen, that it's either temporary or permanent, the length of time can be predicted, and that it can be debilitating and permanent in a small number of men.
Okay. Are there any risk factors that he will get it?
Risk factors would include previous inguinal scrotal surgery, previous history of epididymal orchitis. Those are the only ones I can think of.
Okay. How would you perform a vasectomy?
So I'll ensure that the patient is appropriately prepped, consented, and anaesthetised if necessary. If that is so appropriately anaesthetised, I will identify the vasa on one side first of all, looking to isolate it, and then ensuring that it's gripped between the thumb and the finger. I'll make a 5mm incision in the skin, bring the vas to the surface, and then I'll ligate it using a clip and ties. I'll diaphragmize the ends of the vas, the cut ends. So I'll excise a segment of vas, diaphragmize the cut ends of the vas using bipolar diathermy forceps, and then I will bury the vas, both ends within the subcutaneous tissues, and ensure closure with a dissolvable suture. I'll also ensure the patient has a scrotal support applied at the end of the procedure and local anaesthetic infiltrates the wound.
Okay, the patient's heard of a no-scalpel technique. Do you know what's that about?
So this employs the use not of a scalpel blade, but of sharp dissecting scissors to make the incision. This is associated with a lower risk of wound complications, but the approach is performed in the same manner.
Okay. What are you going to write on the consent form?
So I'll ensure that what is written is the benefits of the procedure. So I'll ensure that the patient's correct details are written, the procedure of bilateral vasectomy, the benefits in terms of producing sterilisation. I'll ensure the complications are listed, including bleeding, scrotal hematoma or abscess, infection, sepsis, epididymolysis, anaesthetic risk, chronic scrotal pain. I'll also ensure that additional points written include any early failure of the procedure requiring a revisional procedure, and also late failure due to recanalization of the vas at a later date. And I'll also list the alternative treatments, which include ongoing alternative contraceptive methods.
Okay. What's the risk of early versus late failure?
The risk of early failure is 1 in 1,000, and the risk of late failure is 1 in 100,000.
Okay. When and how should the patient provide a post-vasectomy specimen?
So they should provide the specimen at least 12 weeks post-surgery. They need to continue to use regular contraception every time they have sexual intercourse, and they need to ejaculate at least 20 to 30 times before they are then producing the first semen analysis sample.
Sorry, when did you say they should provide it?
12 to 16 weeks.
Where does that data come from?
That comes from the BAUS guidelines following vasectomy.
Okay. And how are they going to provide this vasectomy specimen?
So they need to abstain for at least 2 to 5 days, provide the sample in a clean container. They need to transport it to the lab as soon as possible, ideally within 30 minutes. And they need to keep the specimen warm in transit, and that'll be through, for example, keeping it in a shirt or jacket pocket.
Okay.
And through masturbation as well.
Okay. And what's special clearance?
Special clearance refers to the presence of a maximum sperm counts where they can have sexual intercourse, but I can't remember the exact value.
Okay. And you mentioned earlier on about local versus GA. How would you decide which one to do?
So I'll assess them when I examine the patients and assess them in the clinic. I'll determine the level of the ease in terms of isolating, identifying the vas and palpating it, patient discomfort. I'll also know whether they've had any previous inguinal-scrotal surgery, as this may make identifying the vas more challenging when the incision is made, and also patient preference, as well as comorbidities. So those more suitable for a local anaesthetic would be, for example, a thinner patient with no previous surgery, no significant comorbidities, and who is counselled and would agree to go ahead with the local anaesthetic procedure.
Okay. Are there any measures you can take to reduce failure rate?
So these measures would include excising segments of the vas, leaving only the cut ends, diathermising the cut ends of the vas with bipolar diathermy, and ensuring that the ends of the vas are buried in the deeper tissue in separate layers in order to prevent potential recanalization.
Okay. What instructions would you give this patient about post-operative care, including sex?
So I'll advise him that I'd advise him to take regular analgesia for the first 48 hours, to wear either scrotal support or tighter fitting underwear, and that he's to seek urgent medical attention if the entire scrotum becomes bruised and swollen. In terms of sexual intercourse, I'll advise him that he can resume this, but him and his partner need to continue using regular contraception, and that, again, prior to his semen sample, he needs to ejaculate at least 20 to 30 times in order to clear all potential remaining sperm.
Okay. Do you routinely send the vas you excise to pathology?
In my practice, I do not routinely send it, and I'm not aware of any evidence suggesting, for example, the presence of malignancy in such specimens.
Okay. Can you think of any pros and cons to sending it?
An advantage would be to look for any evidence of malignancy. In terms of the disadvantages, it may create uncertainty. I can't think of any other disadvantages.
Okay. So on this occasion, your registrar has actually accidentally sent off for pathology, and the pathology report comes back as not showing any vas. What are you going to do?
So I'll arrange for this patient to be seen again in the clinic. I'll explain the results to him, and the possibility that it may not have been the vas deferens that has been ligated. I'll apologise to him, and I will inform him that further investigations will need to be carried out, and this will determine whether or not the vas has been fully operated on. I'm not sure which further investigations those would be, whether that be an MRI scan or a vasography.
How do you think that's going to help? Doing either of those?
A vasography would determine whether there is full continuity of the vas deferens.
What are you expecting it to show?
So in this patient's case, one would expect it to show contrast fully opacifying the vas if the incorrect structure was operated on.
Okay, so do you really need to do a vasogram?
No, I think if there is the histological evidence that the tissue taken was not the vas, then there wouldn't be an indication then to perform it, and patient would be counselled about a repeat procedure.
Okay. Yeah, that's exactly what you should do. So he's had a repeat procedure. The pathology this time does show vas, but his semen analysis shows persistent motile sperm. What are you going to do?
I'll advise him to continue using regular contraception, but he'll need a further semen analysis. And in terms of the time interval for this, he will need to have it performed, I think, in another 12 weeks. I don't know the guidelines.
Okay, I think that's pretty reasonable. So that's the end of the first scenario, Piyush. Just a couple of things. Special clearance, you can give them if they are, I would say if they've got, if it's beyond about 6 months and they've got consistent non-motile sperm of low volume, so that's less than 100,000.
Yeah.
You can give them special clearance. If you should probably legally always send the path. I know that's a bit variable amongst urologists, because if something this is a really litigious area. If something happens and the patient's partner has a baby, you can't prove that you removed the vas if you haven't got pathology. So that's why I personally would always send it. So that's the main advantage of that's the main reason why you should send it. The disadvantage, there isn't really any disadvantage apart from cost to the trust, which, you know, nobody really cares about that in terms of, you know, if you're in court with this guy, you can't really use that as a reason not to have sent it. But if you did get asked, that's what I would say. The failure rate, it's 1 in 200 for early and 1 in 2,000 for late failure. The chronic testis pain, have a look on the BAUS information leaflet. I think we've updated it recently, I think last year. It used to be 30%. I think it's come down to around 10% now, but it's definitely not less than 2. It's actually higher than we think. What else? I think that was it, really.